Very much, thank you. And hopefully I'll pick up on various points made by Matt, Lauren, Chris this morning. But I'm going to be focusing specifically on work that we've been doing, looking at digital interventions, but actually not targeted directly at children and young people, but for supporting parents. And I'm going to be talking about a lot of work that we've been doing on a programme called OSSIE, which it stands for Online Support and Intervention for Child Anxiety, which has very much come out of our research on parent-led cognitive behaviour therapy for child anxiety disorders. But first of all, I just want to say thank you very much for having me today. And actually, I can very much verify Chris's point that IAPTIS is very good. Because we've had a lot of experience of working with IAPTIS over several years, from when I was previously at the University of Reading, where we set up a research clinic called the Andy Research Clinic, which supported children and young people with anxiety disorders and depression. And it was really critical to us that we were able to collect really good data with everyone that we were working with so that we could really make use of that clinical environment to kind of move forward our practice. So we've been working with IAPTIS there for some time, and I think probably one of the earlier sort of children's services that you started working with, and have just found to be very responsive to all of our needs, and it's been a fantastic system. And we're looking forward actually to now expanding our research clinic into Oxford as well, and very much hoping we'll be able to follow the same model. So huge thanks to IAPTIS for that. So I'm going to focus specifically on anxiety problems, and I'm also focusing specifically on pre-adolescent children, which is probably not where most people are thinking, where they think about digital interventions. Where I think people often just think, right, teenagers, they like digital, that's the space that we should be thinking about. But actually, I hope I'll get across, there's lots of reasons why we can also be thinking about how we can be making the most of digital for younger children as well, particularly when we're thinking about how we can support parents. So on this graph, it really is to highlight the reason that we're thinking about anxiety disorders in younger children is they have a particularly early age of onset. So the vast majority of people with anxiety disorders will first experience them in child and adolescence. And for many common anxiety disorders, like separation anxiety problems, for example, they start very early, so in primary school. And previous data had actually suggested half of all people who have an anxiety disorder in their life would have first experienced that by the time they leave primary school. So clearly there's huge potential for us to get in early and really shift the trajectory of those people's lives. And that's certainly been argued, for example, by the authors of this review, that for these sorts of disorders, anxiety disorders in particular, good mental health promotion, along with preventative and early intervention approaches, really need to target these periods, so in preschool and primary age group. So I'll be talking about primary school particularly, and the general approach that we've taken has been a cognitive behavioural approach, and the reason for that is because when it comes to anxiety disorders, that's where we have the most robust evidence. And there's actually not a lot of evaluation of other kinds of approaches, but we do now have a very large number of trials that have evaluated CBT with children with anxiety disorders and have shown that they're certainly effective, they're certainly better than nothing. We don't know a lot about whether they're better than other interventions because that hasn't generally been tested, but we do know that they're effective, which is more than we know about many other sorts of interventions. But the problem, of course, as many of you will know, is that many children are not accessing those interventions. So we have treatments that we know work for a good number of people, but many children are not accessing them. And a few years ago, we did a study where we went out across the country into schools and we screened children in schools for anxiety problems. And where either the child or the parent or the teacher indicated that there might be a problem, we followed it up and did a full diagnostic interview with the children and their parents and identified children through schools who met diagnostic criteria for an anxiety disorder. So that meant they had a level of anxiety that was severe and it was causing, regular impairment in their day-to-day life and high levels of distress. And what we found was that although about 2/3 of those families had tried to get some sort of professional help, actually very few of them had actually received professional support. So that comes the number down here. And then it was actually about 2% of the children that we identified who'd actually received cognitive behaviour therapy, which is the only evidence-based treatment that we currently have. You just switch those numbers for any other health condition, and I think, it's really striking, isn't it, how what a poor situation that is, or certainly was. Since then, there obviously have been some quite substantial service developments, but I think as others have said, I think we clearly see many families still struggling to access care. So we really need to think about how we can deliver treatments efficiently so we can make the most of the resources that we've got to make sure people get access to treatments that work. And we were involved in an update of a Cochrane review where you analyse all the trials that have been done on CBT for child anxiety disorders. And one of the things that we did in the most recent version is we organised the trials by the amount of therapist time that had been spent on the intervention. And this is obviously small, but the first chunk here are treatments that were delivered with less than 10 hours of therapy time. This chunk were between 10 and 20, and then these ones were over 20. And what this diamond shows you is the size of the effect, so how effective that treatment was. And how far away it is from that line shows you how well it's working. And what you might be able to see is those diamonds are in pretty much the same place, however long the therapist was spending on the intervention. And when you look at those trials, you might think, oh, well, that's because these were probably more severe, these people, where they were offering them longer treatments. They weren't. When you look across the trials, they're very similar in terms of who was seeing them. So that really suggests we can work more efficiently. And of course, I think we've got a duty to do so when we have so many people who are waiting for treatment. One of the very notable things about these top treatments is when they were with younger children, they typically involved working with parents. And when you work with parents, it does bring many advantages because compared to working with a young child, you obviously have to spend a lot of time. They have to get to know you. They have to feel relaxed. You have to sort of break things down so you can use the time effectively. Or you could help their parents to help them in their day-to-day life, and you don't need to do any of those things. And so we've done a lot of work over the years trying to think about how we could do that. How can we empower parents and support them and provide them with the skills to be able to apply cognitive behavioural strategies in their child's day-to-day life. And so children are not having to be brought in for appointments, you're not having to sort of do all the other things that go on around treatment. Parents can just be implementing those strategies around their child. And we've had really encouraging results from this. So this was, sorry, I don't know quite what's happened there, but essentially this was from not a digital version, but we basically had written materials for parents, and then therapists would support the parents in working through them. And because parents could read the written materials outside of the sessions, it meant you could use your therapy time really efficiently and be very focused. And what we found was that after just 5 hours of intervention, half of the children were already free of their diagnosis. And when we followed them up 6 months later, that was almost 80% of those children. So actually the same sorts of results we see from much more intensive treatments. So that was really encouraging. We also looked at the cost effectiveness of this compared to an alternative brief treatment. And what this line shows you is that there was a 96% probability that this guided parent-led CBT treatment was more cost-effective than an alternative brief treatment delivered in CAMS. But we're very aware that, 5 hours is still quite a lot of time if you're a parent, so anyone who is a parent here, when I think about this, I think, gosh, if one of my children need a weekly appointment that involved me driving to Oxford, I don't quite know how that's, how's that going to work? When are we going to do that? I mean, of course you'll make it happen, but that is not easy. So even 5 hours, some of which was on the phone, some of which was face-to-face, it was still challenging for parents. And also we were asking parents to read quite a lot of written material, which is, of course, going to be a huge barrier for many parents as well. So we were really keen to think, how can we make this more efficient, but also how can we make it more accessible in just terms of how we deliver the information. So very much picking up on what Matt and Lauren were saying about the importance of making use of the expertise that is there in the NHS. We work very closely with NHS clinicians, with parents and children who'd had treatment for anxiety problems, with researchers and with a partner tech company to co-design an online intervention. And essentially what we ended up with was this programme called Aussie, Online Support and Intervention. And what it involves is a number of different modules for parents that they work through, and therapists unlock them on a weekly basis after they've had a telephone appointment. So it's sort of in manageable chunks for parents. And text is presented, but you can also just listen to it instead if you'd rather not read it, or if you're doing the washing up and you want to listen while you're doing that. And it's all of the text was we thought we'd written it in this fantastic accessible way, but then some health journalists got hold of it and we realised we hadn't done that. So they made sure it had a very low reading age to make it as accessible as possible for parents. And essentially, parents work through different modules, one by one, and within those they can access information in text, but also some of the simple strategies are illustrated through animations. There are also quite a lot of videos of parents talking about their experience of using the programme, particularly where parents are talking about the things that are a bit difficult, and then how they got through them. And you can obviously use it on the phone, on a laptop or a tablet. Not that nobody seems to use those anymore. And it involves lots of interactive worksheets as well, so parents can kind of put in information and move it around. And there's also so all of the information is provided directly to parents, but there is a kind of optional game app that parents can use if they want to help engage their child in the process. It's really not therapeutic, this game. It's there purely to kind of as an engagement tool to help get children on board and make life easier for parents. Because what parents said to us was, actually, we don't want loads of tasks that we have to try and get our child to do, and it kind of feels like we're asking them to do more and more, and it's just another thing to argue about. But if you could just have something that will just encourage them to kind of go with it, and so when we're saying, oh, let's go and test this thing out, let's go and try this out, there's something that's there as encouragement. So we work with children to create a game where parents can basically give their children rewards within the game. So it's quite fun, because when, say, a child goes and tests out a thought and they learn something new, the parent can go, wow, that was so brilliant that you did that. Let me give you 100 coins in the game. And then the next time the child goes in, the doorbell rings and there's a little present there, and it showers them with coins that they can spend on games and other things within the app. So parents don't have to use it, but it's there as a tool if they want to. And obviously, really importantly, at every session, when parents log in, they need to complete routine outcome measures. So we have all those core CYPI app measures within there and some additional ones that are specific to child anxiety. And so the parents can see their own progress in real time, the clinicians can see that as well as being able to sort of see appointment details and so on. And so we've done some initial evaluation of this so far. And I guess, first of all, I wanted to just share a couple of quotes from the qualitative work, because I think what we've been really trying to do, well, there are two main things, is one, provide this information in a way that's useful for parents and it overcomes the stigma that parents often face when it comes to seeking help for their children. And two, we want to make it more accessible so it can fit around parents' day-to-day lives. So these are just a couple of quotes about this. So the first parent said, face-to-face is great, but at the same time, for a lot of parents, it's that stigma, isn't it, around things like this. So actually, when they can do it online, I think that's a really positive thing. And then here another parent said, I could literally pick us Aussie up and put it down when I had time during the week. Whereas a face-to-face clinic, it can involve taking time off work, booking days off or time off, travelling time to get wherever you're meeting and all that. Whereas at home, I could just, if I had 10 minutes, I could do some. So we were really pleased to have a lot of feedback like that, because it really fitted with what we were trying to do. So the next thing that we did was to offer it within a clinical setting. So this was within the Reading Andy Clinic. So these are children and young people who are being referred into CAMS, and then at the common point of entry, because it looks like there's an anxiety problem, they get diverted towards the Andy Clinic. And there they were offered by the clinicians working in that service, Aussie. And basically what we found were really positive results. We had really good retention, so people who started it, finished it, but also we saw really good improvements in terms of outcomes. I guess the ones that are probably easiest to interpret, maybe through the goal-based outcomes. So parents at the beginning set 3 goals for treatment, and then they monitor their progress towards those out of 10. So they would go from an average of 2 out of 10 on their 3 goals to an average of 7 out of 10 by the time they've had these 7 appointments, which is about 2 hours of therapist input. But we also saw quite marked, and these are all very large effects in terms of all of the outcomes that we assessed. And what we saw is, because we can collect the data at every session, it's built in, so we have it on absolutely everybody, you can see that there is a steady improvement from session to session across all the measures. But one of the things I want to point out is the session rating scale. So those of you who are based in services will know this measure, where it's about how you found the session. It's about how well you felt understood and listened to by the therapist and how useful it was. And essentially the top, this is a bit of a silly graph, the top score is 40. And at 36 is what you would call, okay, that's a good session. And you'll see that the mean score was about 38 all the way, 38 out of 40 all the way through. So despite the fact they're just having 20-minute phone calls with a therapist, that is it, 7 times throughout this session, they are still reporting that they feel that they've got a good relationship, they feel well supported by that therapist. And I'm actually always really sort of surprised and impressed how open people are in that context. So we're just finishing an exciting trial at the moment called COCAT, which has been a randomised controlled trial that we've conducted in over 70 teams across the country. And these have included NHS teams, but also teams where child mental health services are provided by a local authority, but also voluntary community sector organisations. So Barnardo's took part in this as well. And we recruited 444 families to this trial, all being seen in routine services. And we basically just made Aussie available to those services, had just a 45-minute PDF PowerPoint presentation and just said get on with it. So I was quite nervous about this and how it would go. But actually we've seen really good engagement and take-up across those services. And it's slightly frustrating today because the results, it's being analysed as we speak, and I know the results, but I can't share them with you just yet because it's still not all been signed off, but those results will be with you soon, and we'll be really pleased to share them. But what we've been able to do beyond that, because we finished recruiting and many of the services were saying, well, what happens next? Can we keep using Aussie? So while we work out our sort of dissemination model, we've said, yes, keep clinical trials put all sorts of constraints on services. Families have to be happy to be randomised and all these sorts of things. So now we're just saying, yeah, keep using it, and we'll sort out service evaluation arrangements so we can see how the outcomes look as you continue to use it. So that's happening. But also we're very aware that, of course, we saw earlier on that there are lots of families who are not reaching mental health services at all. And many families, their first place they go is school. And with the mental health support teams, we've got a great opportunity to be thinking about, well, how can we deliver these kind of interventions even earlier? And our experience really is that the earlier we get in, the more engaged parents are with them. So we're doing another study at the moment called ICATS, which is about improving identification and intervention for children with anxiety problems through schools. So we go in and do some very brief screening, we give feedback to families and invite them to take part in Aussie, and then we provide the Aussie programme. And again, we've got a very large trial underway at the moment, but from the initial underpinning work that we did, we again can see very similar outcomes to those that we found in our clinical settings. So again, you can see here the goal-based outcomes go from 2 to about 10, and we've got large effects across all of those measures. So this is an early intervention. We're going in year 4, screening children. And then we offer it. And certainly, again, from the earlier work, we can see similar sorts of things. So I think these things we've heard before, but this parent also adds, I feel much more confident now, definitely without a doubt, with this program. It's written in a positive way, because you can feel as a parent, somehow you've caused your child's anxiety. And so again, being able to not only provide something efficient and accessible, but also do it in a way. So we're really pleased that recently that Aussie was included in the recent NICE early evaluation assessment, along with Silvercloud, who are here, but also I'll mention OSCAR, which is a programme also developed by people in our team, which is an online cognitive therapy programme for social anxiety disorder in adolescents, which I'm not going to talk about today, but I definitely do follow up with me if you'd like to hear more about that, because that's got some really exciting results coming out. So just to finish up, I guess, so from our reflections of developing these interventions and evaluating them both in services and school settings, what are the main things we would take away? I think one of them, again, this picks up on points that Matt and Lauren made, is about to really make the most of these interventions, our service structures need to adapt and need to be flexible. So, for example, our treatments involve 20-minute telephone sessions. If your clinic works in 1 hour long slots, then you're not going to maximise the efficiencies there. But equally, so some of our trials, we have our team who are delivering Aussie, In the COCAT trial, we just gave it to clinical teams. Actually, I think they did really well with it. But in our team, those people are just delivering this Aussie in, day out. So if a parent phones and goes, oh, I'm struggling with X, they'll know exactly what to say, and it's not a problem. It gets dealt with really quickly. Whereas if the clinician's not familiar with it themselves, then, it can get it might get muddled, and everyone might get a bit frustrated. So having not just digital products, but actual digital teams and pathways, as Lauren and Matt were talking about, I think will really enable us to make the most of these efficiencies. And so having these digital specialist therapists. And then I think the final point, I think, we've also talked about the importance of the data flow. And obviously it's critical for services that these things create efficiencies. Our challenge when we were creating Aussie was that there were so many different patient management systems being used in CAMS. So which, we didn't have the resources to set up to link up with all of them. So what do we do? And we need to come up with solutions to that. And it may be that there's one that could link up with lots of others, for example, but we desperately need to sort that out, because at the moment we're capturing all the data and services can access it, but it's not smoothly going into their patient management systems. And that's obviously going to be critical for really making the most of the efficiencies that come with this. So I'll stop there, and thanks very much.